my talk. First, I'll talk about the era of HbA1c and its limitations, then the era of SMBG and its limitations, novel metrics, time and range, and some guidelines regarding the time range. Now, the importance of HbA1c really came after the diabetes control and complications trial, or the DCCT trial. And we look at this particular graph. This is the relative risk of various complications, retinopathy, nephropathy, and so on. If you come down to below 7%, the risk is practically eliminated. But if you go above 7%, all the complications, retinopathy, nephropathy, neuropathy, microalbuminuria, all keep increasing progressively with increasing A1C. And that's how the 7% got accepted as the target for everyone with diabetes, with some exceptions. Now, however, HbA1c does have some limitations. What are these limitations? First of all, it does not capture hypoglycemia. So when it gives you a number, 7%, 8%, you don't know how many times patient had hypo to reach that 7%. Secondly, it does not capture individual differences, and I'll show you a slide regarding that. Finally, it does not capture glycemic variability, and for this you definitely need something which measures the time range. Now, this is the example to tell you two patients, patient number 1, patient number 2, both have A1C of 8%. Now, A1C is only an average. If you have a high sugar and a low sugar, the A1C will simply come out as the mean. It's like an arithmetic mean. If you have, let's say, 150, average will come out as 75, isn't it? But if you have higher value and lower value and then take an average, still you can get a 75 average, isn't it? So like that, look at this patient who has so much of glycemic variability. The red shown here are hypos, and the yellow rings shown here are the hypers. So this patient has a variability from this point here, from 50 to 420 or something. So the MAGE, or the mean amplitude of glycemic variation, is very, glycemic excursion is very, very high in this particular patient. But because the average is taken, it comes as 8%. Look at this patient. The minimum is only around 100 or so, and the maximum is only around 250 or so. And then the average again comes out as 8%. So if you're asked, is patient 1's control better or patient 2 control better, using HbA1c, you'll say both are equally good. But if you had the time in range and you had the CGM, you'll say, yeah, both have got the same. But look at the B patient, not much of variation, whereas here there's huge variation. And we know that huge glycemic variation can produce oxidative stress and can increase the risk of complications. Now let's see, can you capture that using SMBG? Why do you need new technology for continuous glucose monitoring? So SMBG, what happens is that you get like a photograph. So morning you can get up and check one sugar, afternoon you can check another one, evening you can check another one, bedtime you can check another one. So you get 4 points like this. Let's say you get 140, 120, 200, 110. Now, these are like 4 snapshots, 4 pictures you've got. How do you connect the dots now? Do you connect this 140 directly to 120 like that? Or do you think it went really high like that and then came down? Let me see if I can get a pointer. Okay, doesn't matter. So now there it is. Okay. See, if you get a point here and then a point here and a point there and a point there, you can join it like that. You can join it like this. It might have gone down and then it could have gone up. So anybody's guess how the sugars are. All you know is 4 blood sugars. Okay. Suppose you had something like time in range to do and the continuous glucose monitoring. This is the actual graph of that particular patient. So you can see that you would have just joined this point from 140 to 120 here. What you didn't realize is that before lunch, the sugars went down sharply. Patient had hypoglycemia. You missed all that completely because you didn't check the SMBG at that time. And you can't keep on taking the glucometer and keep on checking your sugar, poking. First of all, it's expensive, it's very painful, it's very inconvenient also. And there are also accuracy issues. Now, in this particular patient, the next one you have seen is here, and it's gone very high. And the next one was here. Now see what happens at night. Patient has gone to bed, and then throughout the night, the sugars have been very low, which the patient didn't know at all, because when they woke up, the sugars are actually high, because there's something called as dawn phenomenon, and the sugar is going high. Now, if you have a tracing like this for continuous glucose monitoring or CGM, then you can capture the entire profile of the blood sugar of the patient. So the world is now changing, and from HbA1c, we are moving to time and range. It doesn't mean that HbA1c is not important. You still need the average, but the average doesn't tell you many things which the time and range will tell you. Okay. For example, the time and range, as I told you, this is called the time and range. You can set your limit. Now, in this particular case, probably set at 70 being the lower limit, 180 being the higher limit. Within that, if you get all your blood sugar, that is called time in range. Anything above that is called time above range. Anything below that is called time below range, or TBR, TAR, and TIR. So I'll tell you what the recommended normal values are, but several conferences, and this particular one was very important, the Advanced Technology and Treatment for Diabetes, ATTD 2019, where an international consensus was achieved on time in range based on the work of Battaglino et al. And different countries now have started moving to this time in range concept. So earlier, we had just the fasting blood sugar, PP blood sugar. Then the HbA1c is added, and we used to call it as a glycemic triad. Now we call it as a glycemic hexad, or there are 6 things that you should see. First of all, the fasting, PP, and HbA1c is there. Then you can measure what's called as a glycemic variability, as I showed you in that particular graph. And then you can look at all hypos, particularly nocturnal hypos. So if you add all this, you're actually getting 6 parameters which you can measure if you do continuous glucose monitoring. Now, glycemic variability refers to the fluctuations in the blood sugar. That means it captures the peak, it captures the trough, and how much within day or day-to-day variation is it. That is what we call as glycemic variability. And as I mentioned, it leads to high oxidative stress and increased risk of hypoglycemia, also increased risk of both micro and macrovascular complications. So here is a poll question for you. According to you, we are asking you this question, and what percentage of patients experience high variability among type 2? In type 1, we know almost everybody has high variability. In type 2, what percentage of patients experience glycemic variability? Is it less than 10%, 10 to 25%, 25 to 50%, or more than 50%? You can take a guess and mark what you think is important, and then we'll see what the audience felt. There may not be one answer, there will be more than one answer. Give it another 5 seconds. Please pick one of the answers. Okay, so that's what most of you feel. C comes out as a winner, 25 to 50%. You're probably right. You're probably right. It's definitely not less than 10%. More than 50%, this is probably dependent on the duration of diabetes. So that would be the correct answer. For example, in somebody who has only 1 year duration, you may not get much glycemic variability. But as you go on, 5 years, 10 years, 20 years, 25 years, type 2 patients start behaving like type 1 patients. And more than 50% can have glycemic variation. So your answer, probably 25 to 50%, is right. Shall we go to the next one? Let's see. Okay. Now, a few more words about glycemic variability. Glycemic variability is associated with markers of endothelial dysfunction as well as cardiovascular damage. In patients with type 2 diabetes, high glycemic variation has been associated with cognitive impairment. So if your sugars are going too low and too high, especially in an older person and also in children, your judgment may start getting affected, especially in very young children below 7 years of age and so on. If you keep continuously getting hypos, your brain function itself may start getting affected. And in general, patients who get these hypos frequently, their cognitive impairment may set in. And of course, there is also increased risk of mortality in patients with acute myocardial infarction. For example, if you get a severe hypo, it may trigger an arrhythmia and you can actually die. Now, what is time in range? I already showed you that graph, time in range. So time in range of TIR refers to the amount of time that is spent within the range. You can set different ranges, and I'll show you in a minute that there are different ranges for different conditions. For example, the usual one which is taken is 70 to 180. So shouldn't go above 180, shouldn't go below 70. But in certain situations, for example, in pregnancy, 180 is too high, so we set it as 70 to 140. And as I said, anything below 70 is TBR or time below range. Anything above 180 or 140 is time above range. Now let's move on to some of the comparisons between HbA1c and time in range. Many people are resistant to this, including many of my own doctors. And I tell them, sir, we already got all, why are you doing all these new things? You know, there are something called as early adapters and late adapters. The late adapters are called as laggards. And so the early adopters always want technology. They want the latest things because they want to keep moving with the time. Then there are the Chalta Hai kind of people who say, hey, come on, yeah, what is new thing there? HbA1c itself we are not doing. Why should we do this new thing? There are people like that. You must remember that scientifically, if you see, HbA1c compares every 3 months, and as I said, it doesn't capture hyperglycemia. There is no correlation to the patient-reported outcomes. To our mind, we are looking at retinopathy and nephropathy. But patient is worried about hypoglycemia, quality of life. That HbA1c doesn't tell you. Okay, time and range gives you the continuous glucose profile, like a video recording. It captures all the glucose levels. It tells you what happens after every meal. It tells you what happens after exercise. It's related to patients' symptoms. When patient feels, a particular symptom, he or she can check immediately, and therefore the TIR has definitely emerged as a very important parameter. Now, can you correlate the two, the HbA1c and TIR? Well, there are studies done with type 1 patients as well as in type 2 patients. If you want a HbA1c of around 7%, your time in range should be 70. So 70% of the time it's under control, you'll get HbA1c of 7. If you get 90% of time in range, your HbA1c will go to 6. And if it's 100%, then your time in range will be, then your HbA1c may be 5.4, 5.5, and so on. For type 2 diabetes, similar, except that if you get the TAR of 70, your HbA1c can be even 6.7. So in type 1s, it is 7, and in type 2s, it is 6.7. Doesn't matter much. So 70% for both type 1 and type 2, you're able to get, it's very good. Now, this is what I said, that the normal variation itself, the normal values itself, differs depending on what situation you are in. For example, an ordinary type 1 and type 2 patient, this is the commonest that we use. 70% should be between 70 to 180. Above 180 also, we then divide it into 180 to 250 and above 250. Above 250 is very high. Less than 5% of that should be there. Less than 25% should be above between 180 to 250. Totally less than 5% should be in the time below range. And within that, below 54 milligrams or 3 millimoles, less than 1% of the time only you should have. Okay. If you take pregnancy, as I told you, it's a different situation where we want between 70 to 140, not 180. And more than 70% it should be there. And the rest of the 25%, it should only less than 25% should be above 140. And of course, we don't want much of hypoglycemia also. In older people, you can see again slight differences. We don't want any hypos. So less than 1% of the time it should be below 70%. And here for older people, we are saying to get 50% TIR is sufficient. You don't need 70%. Somebody 75 years old, you don't want 70%. Even 50% is enough. So why are we so bothered about TIR? Because if you reduce the TIR by 10%, let's say from 70 it comes down to 60, your retinopathy risk increases by 64%, nephropathy risk by 40%, and neuropathy risk by 25%. We know that the HbA1c, every 1% A1c, it increases the retinopathy and nephropathy risk by 25 to 30%. Now we know that through time and range also, it comes down by just 10%. If it comes down, your risk is increasing very markedly. Okay. Now, in the glycemic variability, I'm just setting the stage for Professor Shashank Joshi to take over. When you have a lot of glycemic variability, when your fasting sugar itself is not controlled, one of the best things that you can do is to introduce a long-acting insulin analog, and glargine would definitely fit the bill, whether it's glargine U100 or U300, doesn't matter. If you use one of them, you can get beautifully the sugars under control. You can reduce both the peaks as well as the troughs. In other words, the range becomes much more narrow when you have uncontrolled diabetes. And just going to show you one case study of early insulin given at the time of diagnosis. In this particular case, I had used glargine given at bedtime in a newly diagnosed patient who, when he presented, the sugars were extremely high. What are the time in range? Zero. Just diagnosed. He has come to me. A1C is very, very high, about 12%. And already somebody had started some oral anti-diabetic drugs. And this was the situation when he came to me. So I told myself, no, this is not going to work. He's got leukotoxicity, lipotoxicity. So I started him on glargine at bedtime. And you can see that promptly by day 5, the sugars have started falling. And then the night, the sugars are under control. Slowly, the daytime control is also improved. By day 9, from 0%, the time in target has gone to 99%. And the time above target from 100% has come down to 1%. At the end of the first 2 weeks, if you take the average, only 47% is under control, no hypos. So no time below range, it's zero now, okay? But time above target is still 53% because the first 5 days, it is about 100%. So what we did was, is this going to last? And what happens if you continue the insulin, short-term insulin given at the early in the disease? So the second one, we put a second AGP, a second sensor. And you can see now the time in target varies between 95%, 98%, 99%, 100%, 100%, 100%. This is why I said early in the diagnosis of the natural history of diabetes, when you have short duration, it's possible to achieve all this. As you go on, 5 years, 10 years, 15 years, 20 years, to get 100%, 98% is almost impossible. And that's why we settle for 70%. Because in this kind of situation, we bring the A1C down to below 6 easily at the time of diagnosis. But as you go on, to get to 7 itself will become very difficult. So you can see that in this particular patient, at the end of the second week, 98% is under control. Many days, even 100% is under control. Time above target, which is 100%, and now becomes 0%. Okay, not even 2 weeks, not even 1% of the sugar is under control. There are a few hypos you can see, 5%, 4%, but these are like for 10 minutes, 20 minutes. They're insignificant. They're not really hypos. So we can say that we got a near perfect control. And how did we achieve it? By adding a basal insulin analog, that is glargine, to this patient given at bedtime. So the conclusion is time in range has emerged as a novel metric in assessing diabetes apart from the fasting, PPG, and HbA1c, and the use of this basal insulin analog has helped to achieve this. And that is what I think Dr. Shashank Joshi will be talking about. So I'm going to stop here. And after he finishes, we can take the questions. Over to Dr. Arjun Naik.
Yeah, thank you, sir, for that wonderful presentation on time in range and sharing your clinical experience also, how timely insulinization can tackle this. So before handing over to Professor Joshi, I have a question to the audience. Maybe I can share my screen now. Yeah. So I hope this question is quite relevant to ask in this current challenging situation that your patients on insulin will be facing. So here we would like to understand from you, what is the most common issue that is faced by your patients on insulin, especially in this current situation? Is it lack of adequate monitoring in the times of restricted movements? Is it due to some compromised insulin dose adjustments and titration? Are they concerned more about hypoglycemia, nocturnal hypoglycemia, or do you see patients discontinuing insulin therapy during this period? So kindly share your opinion and click on the submit button. We will take another 5 more seconds before we close this poll. May I request all our audience to kindly mark an appropriate option and submit. Maybe if majority of our audience have voted, I would request my technical team to kindly flash the results. So majority of our audience have voted for lack of dose adjustment and proper titration. So that has been the common most important concern on people with insulin during this time. So thanks for your response. I would request Dr. Joshi also to comment on this on his presentation. So now we would like to understand what are the advantages of basal insulin, especially in the current challenging situations, and how that newer basal insulin compare against each other in their time in range profiles. Are there are more similarities or more differences between them? So to deliberate on this subject, we are greatly privileged to have Professor Shashank Joshi, who heads the Department of Endocrinology in Lilavati and Bhatia Hospital at Mumbai. So Professor Joshi is the chair of IDF Southeast Asia region, and he is the president of the Indian Academy of Diabetes. He is the recipient of many national and international awards, including the Padma Shri Award from the President of Republic of India. He had adorned various prestigious positions, including the past president of RSSDI. So Professor Joshi is the emeritus editor of the renowned Journal of Association of Physicians in India, and the chapter chair of the American Association of Clinical Endocrinology. With that, I invite and hand over to Dr. Joshi. Over to you, sir.
Oh,
Sir,
Arjun,
shall I unshare my screen, sir, or you want me to continue?
you can project my slides. I'm quite okay. So Arjun, thank you for that. So thank you for your kind words, Arjun. And I think Professor Mohan has said the very nice light. No, keep the slide. I'll when I raise my finger, you change the slide. Go to the previous slide, please. Okay, go to the previous slide, please. So Professor Mohan has actually laid down the foundation of time in range or glucose in range as a concept. And we are living in unusual times. We are living in strange times, and digital diabetes care and diabetes technology is going to get very closely intertwined with insulinization. So in an insulin using person living with diabetes, I think time in range plays a key role. And we are trying to innovate constantly on the molecules of insulin. So what's the next generation basal insulin? And when you look at the next generation basal insulin, it becomes very crucial because NPH was originally the gold standard. And we had a 1/3 reduction from NPH to glargine on nocturnal hypoglycemia, anytime hypoglycemia, 24-hour hypoglycemia. So we moved from a generation of NPH in the 99th year of insulin discovery to glargine, which became the gold standard at the turn of the century. 99-2000 is the time when glargine got available. And then after almost a decade and a half, we had the birth of a U300 glargine, which became the Gen next basal insulin. And that's closely competed by their competitor. So what we are going to discuss today, next slide, is fundamentally looking at the next generation basal insulin. And as I said, we are in changing times. So in changing times, we need to initiate insulin early because we are still having a large population of diabetes with an A1C which is very high, 8.5 and 9. And I think any person who is swimming at 9.5 is symptomatic, has poor appetite. I think basal insulin is the second line after metformin after insulin is well controlled. So remember, that's something which we know very clearly. Somebody has weight loss, somebody is lean, somebody has all the osmotic symptoms, and the A1C is above 5%. It's clearly there. So it's important to recognize that. We have a lot of other therapies which have tried to cloud the space. If there's atherosclerotic vascular disease, if there is heart failure, if there is chronic kidney disease. But remember, even in each one of them, insulin is not a contraindication. Insulin can very much be given and should be given. In fact, many a times after ICU, IV insulin, we should switch them to a next generation basal insulin rather than just moving them to tablets. Of course, we have some compelling medications like GLP-1 analogs and SGLT2 inhibitors, which have made some compelling conditions. But remember, insulin is the world's oldest drug on planet Earth. All oral agents came after insulin. So when you're using the oldest drug on planet Earth, we need to see which is the best bet, because the most physiological option in insulin space is actually basal insulin. And in that, as I said, the gold standard is glargine. And do we have some better incremental innovation on glargine, which is U300 glargine, or the 2GO as they call it? Next slide. So clearly, basal analogs have a clear advantage. Not because company A or company B makes it. Today, my duality of interest with Dr. Mohan is Sanofi Aventis. They are the innovators of Glargine, which is Lantus. And they also are the innovators of Toujeo, which is U300 insulin. It's simple and convenient to initiate. It is easy and safe to titrate. There is no titration hypoglycemia risk involved, or it is mitigated to a great extent. There is a very smooth maintenance following an active titration phase. In real world, it is effective, and even in RCT, it is effective. And what we are going to understand today is it has less glycemic variability. Not only it has a lesser coefficient of variation in the subcutaneous tissue space, which we are exploiting as a pharmaceutical reservoir, but it has a less glycemic variability. It has a much better time in range, which Professor Mohan alluded to, less hypoglycemia, less weight gain, and very easy to use. Just dial the dose. It's very flexibly to be used with oral agents. It improves patient satisfaction and quality of life. It's very easy to use on remote management, digital management. It is easy because it's once a day, and you can easily switch it from any regimen. So it's very integrated insulin. See, it doesn't have too many barriers or challenges, which a lot of complex regimens like premix insulins can have. So probably in ease of use, in adherence, in access, I think basal insulin is right up there. And basal insulin analogs like Toujeo have some advantages. So let's study them. Next slide. So let's look at a question here. Arjun did ask us very good questions in the beginning. According to you, which is the most clinically relevant advantage of a second generation insulin like Toujeo versus a first generation insulin, which is there? Is it low anytime risk of hypoglycemia? Is it lower risk of nocturnal hypoglycemia? Is it ease or safe of titration leading to optimal dose administration? Is it effectively fixing fasting leading to lowering of PPG excursion? Is it longer duration of action beyond 24 hours addressing variability? So this is how we would see a patient in the clinic. So your time starts now. Let us see your poll. You have the answer. So as most people thought that the longer duration of action is very compelling, 45% of the audience thought it. Then ease and titration and safety was 19%. And then there was a tie between low nocturnal and no anytime hypoglycemia. And fixing fasting first for PPG excursion really was at the lowest pecking order. Pretty good, pretty true, but let's look at science now. So let us close this. Next, go ahead. So how do two basal next generation insulins or second generation insulins compare with each other? Next slide. That's the next question now. According to you, how does a U300 Glargine differ from a Degludec in clinical practice in terms of glycemic variability and time in range? A, there are more similarities than differences between clinical practice between Glargine 300 and Degludec, or there are substantial differences between Glargine 300 and Degludec? The time starts now. Well, it's like almost like a tie. Today, US is going for elections, and you can see it's a 52-48 tie. So actually, half my job is over. If it was more than 50%, I was going to tell Arjun and request Professor Mohan to go for question and answers. Because most people, if 48% of the audience feel that there are substantial differences between U300 Glargine and Degludec, but a large 52% still feel that they are all the same. So let's look at the differences. So I really have to convince the 52% of people that there are subtle differences. So what are the evidences of U300 Glargine versus Degludec on glycemic variability and time in range? So first is we have four categories here. Do we have pharmacokinetic, pharmacodynamic data in type 1? Do we have a randomized control trial in type 2 diabetes? Do we have another randomized control trial in type 2 diabetes? And do we have real world evidence in type 1 diabetes? So clearly we have adequate, sufficient and compelling data to show that if you give a morning U300 glargine or a Toujeo, zero point 0.4 unit per kg per day, it provides a less fluctuating 24-hour pharmacodynamics and a much robust pharmacokinetic profile head-to-head in a clamp study compared to degludec. So on the pharmacokinetic pharmacodynamic front, probably there is a numerical and a statistical advantage and a physiological advantage of a U300 glargine versus a degludec. But we are today in a data science, we need randomized control trials. So when you look and compare the efficacy and safety of glargine versus degludec in people with type 2 diabetes in a randomized open label crossover study using CGM, which is the gold standard, we'll see some data on that. Then of course we have an RCT where we are comparing U300 glargine, which is Toujeo, versus degludec using the AGP as a randomized crossover study. AGP we know is the flash glucose monitoring, which is the Libre or Libre Pro. And then finally in type 1 diabetes, which was seen in a routine care in Spain called the One Care study, we look at the effectiveness and safety of a U300 glargine versus degludec on CGM of adults with type 1 diabetes. So we are going to look at and study each of these four criteria for that 48% of who feel that there were no differences. Let us look at the data. Arjun, next slide. So this is Tim Bailey from California and from the Scripps Institute, and he has made a single center randomized double-blind euglycemic clamp study, including 2 parallel cohorts with a fixed once-a-day morning regimen of 45 people. And this is compelling and overwhelming data. For the same dose, there is 20% with less within-day variability with U300 glargine or Toujeo compared to degludec. So obviously, the Toujeo or U300 glargine provides a less fluctuating steady state of pharmacokinetics and pharmacodynamics on a more evenly distributed pharmacokinetic population if it is given a single dose. So this is head-to-head data in an experimental lab, the gold standard being euglycemic clamp study, and this is a published data which is published 2 years back. Next slide. Let's look at the next study. It's the CGM study in type 2 diabetes and RCT for time in range, where we are looking at studying the efficacy and safety of a U300 glargine versus degludec using CGM. It's a randomized crossover study with 30 patients with type 2 diabetes with either U300 glargine or degludec, and CGM done for 5 days on each treatment. And the mean percentage for the time within the target glucose range or glucose in range was studied as an efficacy endpoint. Next slide. So this is a Japanese study clearly showing that the time below range was markedly lower for glargine 300. So for a comparable time in range, the U300 glargine versus degludec, the time below range was markedly low for U300 across all categories of hypoglycemia. Whether it was anytime hypoglycemia, nocturnal hypoglycemia, severe hypoglycemia, there was a robust science to show that the time below range, or when it comes to hypo, I think there is a clear advantage to Toujeo compared to degludec, and that data in the CGM space and in a very, very elegant journal a year back has been published. Next slide. When we look at the AGP and again do a randomized crossover study of degludec versus glargine in a very meaningful way to look at time in range between 70 to 180. This is Yamabe study, again Japanese study, 1-year-old study. Next slide. Clearly shows that with the Libre Pro, you can see that there is a significant percentage of lower nocturnal hypoglycemia with U300 glargine, which is statistically significant than the degludec. So clear data on nocturnal hypo also. So the data is pretty compelling now. As we are understanding science better and we are generating data, you can see that the data is robust. Next slide. Then this year at the ESD, there was this One Care study which was published. This was the first real world evidence in an adult type 1 diabetic population from Spain. And this was the virtual ESD which was there, and this was basically presented from the Spanish group, and that clearly looked at the CGM monitoring of adults with type 1 diabetes in routine practice in Spain, which is what we all do. Next slide. And this was the trial protocol. You can see they had the glargine U300 switchers and the degludec switchers, and they were adult type 1 diabetics which are all on basal insulin first generation were switched. Either 104 patients were switched to Toujeo and 95 patients were switched to a degludec. And CGM was analyzed and maintaining the current treatment for 3 months. And they looked at the primary endpoint of time in range, the secondary endpoint of time above range and time below range, and the safety for hypo and hyper. Next slide. Pretty representative crowd. And you can see when you look at time in range profiles of head-to-head U300 glargine versus degludec, similar time in range, time above range, time below range between glargine and degludec full day 24 hours. But when it comes to the night period, which is from midnight to 6 a.m., there is a statistically significant difference which is observed with the U300 glargine for time in range and time above range. That's something which we need to make a note of. Next slide. When you look at the safety profile, in the total number of hypoglycemic episodes, there was no difference observed head to head. But in the nighttime hyperglycemic episodes, about 250 were lower with the U300 glargine. So obviously you are not getting the night spike. See, we are only looking at night lows, but remember there are night spikes also. The night spikes are equally important. So if you look at the quality of life questionnaire or the satisfaction with treatment questionnaire, it was similar between the treatment groups, and that whole mean global score of 27.8 is a very, very high level of treatment satisfaction. So that the DTSQ stands for Diabetes Treatment Satisfaction Questionnaire. And again, you can see that the time above range or the peak, the night peak is actually blunted by a Toujeo, but not with a degludec. Next slide. This was the 1K data in type 1 diabetes. So 1K showed in the real world that clearly if CGM can direct a second general basal insulin analog, probably the U300 glargine, looking at the full day time in range, is very similar to degludec and mirrors the results of type 2. But the time in range for the nighttime period for time above range clearly shows that glargine has not only an advantage for nocturnal hypoglycemia, which we already documented in another study, but actually has lesser hyperglycemic spikes. So the peak or the spike is blunted. And that was the conclusion at the ESD from the Spanish type 1 adult cohort of the typical analog of the U300 Toujeo. Next slide. So if you compare the second generation basal insulin in light of time in range, when we revisit that, what do we already know? We know that all the second generation basal insulins have a favorable glycemic variability profile compared to first generation. That data is pretty clear. What is new? That among the second generation basal insulins, the U300 glargine has a better safety profile in both time below range and nocturnal hypo, head to head versus degludec. And the 1K real world study, which was just a head to head study, showed very clearly that U300 glargine spend more time in target in glucose in range at night and don't get the hyperglycemic spike which the degludec can get. If you look at the relevance of the evidence from the current situation, obviously there is a better glucose in control, better time in range. When we look at all these challenging situations, and it's particularly relevant in challenging times like this, because we are all probably homebound to a large extent. Our diabetics who take insulin are under anguish, are under challenges. And I think this is the compelling data to show that pretty much the nocturnal hypoglycemia is mitigated and the nocturnal hyperglycemic spikes are also mitigated. So basically, we are trying to keep the nocturnal glucose in range. And that is something where the U300 glargine has an advantage. Next slide. I think we have tried to show two things. One is that time in range is here to stay. and we are getting more and more technology, which is going to intrude into the lives of doctors and lives of patients. And second is we are going to get better and better insulins. And in that, we need as clinicians to take some meaningful choices. I'm very, very happy that I could share this podium with my elder brother, Dr. V. Mohan. Om Sai Ram, sir.
Thank you very much, sir, for the wonderful and lucid presentation. So, without doing ado, what we are going to do a question and answer session. And our first question is to Dr. Mohan, sir. This is from Dr. Ashok Kumar, Chennai. That is time in range measurement economical? And with the similar line, we also have the question from the Bangladesh, Dr. Shahzada Salim from Dhaka, who is saying that for the patients with diabetes in India or in Bangladesh, how easy to have CGM done to document time in range, as many of the patients may not have the financial soundness. So both these questions are aligned in terms of economical relevance with the time in range.
Let me answer it now. There are many ways of doing CGM. There are many machines with which you can do it. For example, the Dexcom one is very expensive. In fact, they're not even marketing it now in India. It's too expensive. Whereas you take the Abbott products, the Freestyle Libre and the Libre Pro, they are both available in India. The Libre Pro is reasonably cheap. For example, if you talk about 2,000 rupees is the cost of the sensor, 1999. So 2,000 rupees is the cost for 14 days. Okay. So in 14 days, it gives you 1,440 readings. So if you divide that by 2,000, it costs a little more than 1 rupee for one reading. And we can put it as 1.5 rupees for one reading. If you do a SMBG, it costs 20 to 25 rupees per strips. It can go even up to 30, 35 rupees per strip. So if you do it, let's say 3 times a day in SMBG, you need to do it 5, 6, 7 times a day. And with this continuous glucose monitoring, you can test it 20 times a day, 30 times a day. If you want, you can get readings with the Freestyle Libre, for example. Now, if you calculate that, let's say you do 4 blood sugars in a day in SMBG, that's 100 rupees in a day. You multiply that by 14 and you see how much you're going to spend on that particular thing. And it's going to work out much more expensive. Then second thing is the cost. You're going to pay each time, you're going to pay. Third thing is the pain. So each time you have to poke yourself, poke yourself, poke yourself. How many times you're going to take poke yourself? Then, as I showed you, you still get only snapshots. You get one here, one somewhere there, one somewhere there. How do you join those dots? You can't just join it like that. So that is not how the sugars would have gone. So it's a difference between, you ask me, if you take a photograph, is it cheap? Or video, is it cheap? Well, the video may be a little more expensive, but the video is giving you a complete movement of what I'm talking now, my every moment. Otherwise, you'll just get one shot now of me, okay, and say, it's cheap. I just got one picture of Dr. Mohan now. Whereas everything that I'm saying now, with the audio, video, everything we're able to get in a video, it's completely two different technology. So I think if you take the benefits of that, picking up every hypo, finding out a new parameter time and range, which you cannot even do with SMBG. It's very, very difficult. Glycemic variability, to some extent, you can do that, doing mean and standard deviation. But again, it's not that accurate. Here, you know every blood sugar throughout the day for 14 days. So if you work that out that way, then I would say it is not all that expensive. People keep talking about the cost of diabetes treatment. Dr. Shashank, Joshi and I always keep saying one thing, and that is treating diabetes is not costly. Not treating diabetes is very costly. Why is that? Because you don't treat diabetes, you'll end up with diabetic kidney disease and eye disease and so on. Just take diabetic kidney disease. If you take diabetic kidney disease, every dialysis, you'll be spending 3,000 rupees per dialysis, 2 to 3,000 rupees, and even more. And if you develop any complication, it's going to go much more. 3 times a week dialysis into say 3,000 rupees is 9,000 rupees. Even if you make it 2,000 rupees, very few people do 2,000. Even then it's 6,000 rupees a week, which means into 4, 24,000 rupees a month, into 12, 3 lakhs of rupees just for the dialysis. That doesn't count the medicine cost, doesn't count other costs that you have to take. So 2 to 3 lakhs per year, you want to remain alive. And what is the quality of life? You're going for dialysis, in, out, all the electrolytes are going to change, everything. Just imagine the quality of life. So, and if you stop it, you're going to die, okay? You ask people to spend 10% of that, okay? 3 lakhs is spending. If you ask them to spend 10% of that, then for 10 years itself, you would not have spent 3 lakh. But people say, oh, 20,000 in a year. How can I spend 20,000 in a year? Well, then many of them start spending 20,000 in a week or in 2 weeks' time. So this is being penny wise and pound foolish. It's like the example I always give is it's like taking insurance. You buy a 50 lakh car, but then you don't want to spend 5,000 rupees on insurance. Oh, why should I spend 5,000 rupees on insurance? You bring the car out, a 50 lakh car, and you hit something, you'll spend 3 lakhs repairing it. A simple, a light can cost you 1 lakh in a big car. So for that, but then people will hesitate and say, no, I'll save that, 5,000, I'll save on the insurance. It's like that. So people don't realize it. When we ask them to do some test, people think, oh, he's trying to make money out of it. What money? 50 rupees for some test and 100 rupees for a test. Is that money for us? It is to find out what tests you need to be done for you, because unless you keep all those tests under control and unless you monitor them, you're not able to prevent the complications of diabetes. So diabetes is not costly. Treatment for diabetes is not costly. Tests for diabetes is not costly. TIR is not costly. Not doing all this and ending in complication. I just showed on data to show that a 10% decrease in TIR results in a 64% increase in retinopathy and more than 40% increase in nephropathy. Just 10%. How will you even measure it? If you don't even measure it, how will you know that you dropped 10% in your human brain? You can calculate all your blood sugars. It's not possible. And that's the reason why I think you should not calculate the cost like that. The doctors who ask those questions also think about these, whatever I told the unit, is there any exaggeration in anything that I told you? Technology comes, usually there is a cost attached to it. Later on, the cost will come down, okay? And people are willing to spend so much on an iPhone or on something else, but they're not willing to spend on one glucose thing to see your own blood sugar to ensure that you have a long and healthy life. We have shown that people can live up to 95, 100 years of age without any complications if you do simple things and look after yourself. So again, I repeat, treating diabetes is not costly. Not treating diabetes is very, very costly.
Thank you, sir. So the next question is to Dr. Joshi. So this is from Dr. Patel as well as from Dr. Ray. So both we have the same question, that is, when Lantus or when Tuju? So they're asking the patient profile when we are going to select a first generation basal insulin or a second generation basal insulin.
So for me, the answer is very simple. Actually, Dr. Mohan has already given the answer. If my patient can afford it, I would give him the best insulin, which is Tuju. So that's not a brainer at all. If, of course, you can't have an affordability as an issue, because I'll tell you, insulin is like an insurance. And even the CGM cost or the time in range cost is like an insurance. Because if we get better glycemic control, we are going to keep the person complication free. And the complication cost is the big cost or the hidden cost in diabetes care. It is not the care of diabetes which is expensive. It is the care cost of complications which is hidden. So if you ask me from pharmacokinetic standpoint, pharmacodynamic standpoint, I want my patient to get the best of class. I have an advantage over them. See, how am I differentiating? I definitely have an advantage. So let me now segregate the question. So the simple answer is, if there's affordability is not an issue, it is always the U300 glargine or Tujo above glargine. But in the choice, I am middle class, I can just about afford, I have to stretch a little bit. If I am type 1, or if I have a diabetic kidney disease, or if I am elderly, my choice or preference to use Tujo is higher. Because I know that the time in range is very crucial for elderly. And we have data from BRIGHT study, which was published again last year. Then in the renal situation, we know that glycemic variability matters, time in range matters. Again, I want a little better insulin for the kidney handling. And obviously in type 1, there's a clear advantage. So for a type 1, for renal, for elderly, I would still prefer the Tujo. But if I have a garden variety type 2, who I feel just doesn't, he has to sell his house to buy a Tujo, I would give large in there. So we need to understand that we have to balance it, but this is a cost issue and we have to do shared decision making. So in the cost issue and shared decision making, my preference will always be to use a better agent if there are some pharmacokinetic, pharmacodynamic, real world and RCT advantages. And we have seen all of them. So if you look at pure science, obviously it's a better molecule. But where does the time in range matter? Which is what Professor Mohan alluded to. It matters in those areas.
Thank you, sir. Our next question is to Dr. Mohan, sir. That which are the patient profiles which are ideal to go for CGM, as in our setting it's impossible to do it for all.
Yeah, we understand that it's impossible to do it for all. Wherever possible, I think it should be done. For which patient you will do fasting, which patient you will do postprandial, which patient you will do HbA1c. In every patient you will do fasting, BP and HbA1c. So once it becomes a routine of care, almost everyone you will do it. Now, if a patient has, let's say, fasting very well controlled, BP very well controlled, HbA1c very well controlled, no hypos, everything is fine, probably we can skip doing the TIR. Any patient where we are starting new treatment, intensifying the treatment, adding a new oral drug, the HbA1c is already high, we want to know whether it's getting under control. We don't have to wait for 3 months to find out. Someday after 3 months, it will go even higher. So you wasted 3 months' time. If you start the patient on the CGM, you will know in 2 weeks' time whether you succeeded or not. And then you can make mid-course corrections to see that the next A1C at least comes down. Whenever you're starting insulin, then it is needed. I would say in every patient with type 1 diabetes, you should use it fairly continuously. I had one patient, in type 1, whose sugars were not at all getting under control. So we used a couple of the Freestyle Libre Pro. We had used a couple of times before the Libre came. So third time when I told them to use it, that the mother was asking, "You already done it twice. Why do you want it 3 times?" I said, "The people who wear it all the time. Every meal they want to check whether it's under control. Without Freestyle Libre or its equivalent or Dexcom or Medtronic or one of those brands, using a CGM, type 1 diabetes is hardly treated in the West. It's a kind of, a part and parcel of type 1 treatment. So where's the person saying I used it twice, I used it thrice? It's not like, I had idli once, therefore why should I have idli again after 3 days? You have to eat again, you have to have your idli again, So like that, these are all becoming part of the treatment itself. So once you make people understand, then they will probably, and the best thing is that we must teach them what to do with it. You find a high sugar, what do? You take your insulin earlier, increase your, the preprandial insulin dose a little bit, then you bring it down, or you exercise, or you take it a little bit earlier and see whether it comes down. So many ways or reduce your breakfast, split your breakfast, take it twice. There are so many tips we can tell them. Once we make it fun for them, and once you get them involved in it, then it becomes easy. If you just, give them some blanket thing and then tell them, then they think you're not. It's like SMBG. Even SMBG, when the patient brings the SMBG and shows it to you, if you kind of brush it aside and say, okay, I don't have time for this, that patient is never going to do SMBG again. Whereas you get them involved and tell them what to do, they will do the SMBG also, or the time in range also, they will look at. I think there's one question, Dr. Monica. She asked which insulin you initiated in the patient's AGP should. I told you it was the glargine itself, glargine 100. That is, patient was a few, a couple of years ago, and it was just plain and simple glargine U100 which I used in that patient.
Yes, thank you, sir. Maybe I can ask one question to Dr. Joshi now. This is from Dr. Devan Sanchania. So Dr. Devan Sanchania wants to know, is there any advantage of using glargine U300 in the morning instead of night as far as glycemic variability is concerned? And also one more question from Devan Sanchania is that, what is the maximum dose up to which glargine U300 or 100 can be titrated based on the fasting blood requirements?
So the first question is that you can give this anytime. For Lantus, bedtime was suggested, but we knew that when Lantus was marketed in the beginning, at the turn of the century, we called it peakless. Now we know that there is a small peak. That peak occurs between 17 and 18 hours. So clearly a bedtime insulin to control the hepatic glucose production and for fixing fasting first as a concept was more applicable for glargine. But when it comes to Tujo is actually truly a 24/7 insulin. So you can give it at the same time every day and it could be any time. So remember that very, very clearly. So there is no issue at all on that front. What was the second question, Arjun?
Second question was on the dose, sir. What dose we can update?
So insulin is one agent when there is no upper dose limit. We know the pharmacological definition by Goodman and Gilman of insulin resistance is more than 200 units a day. Okay, so in that perspective, there are people, if they are crossing total daily dose requirement of 200 units, which is rare, but it's not unusual. Usually it is seen in people who are exquisitely insulin resistant and who are obese or who are classical type 2s. We do have those higher doses. So remember that insulin does not have an upper dose limit at all. Neither glargine U100 nor 300 has a glargine. You all have caps because of the way it is packed. So the way, if it is a vial, if there is a cartridge, if there is a pen of U100, there will be a differential. If there is a, usually the tujo always comes in a pen. So based on that, there is upper limit. Some will have 80 units, some will have 100 units. So it is basically a manufacturer's issue. But as far as the upper dose range is concerned, there is no upper dose range. So remember that. But any human being, if he's consuming more than 200 units of insulin per day, he is pharmacological insulin resistance and needs redressal of that on various mechanisms. That's a separate topic of discussion by itself. So insulin resistance, which is seen inside de novo, is very different from pharmacological insulin resistance. That's a very clear-cut entity. So remember that overall that cut point is 200. If somebody wants to put me on a gunpoint and say MCQ, put a number, then it's 200.
There are three quick questions here I saw. Can I just take them? Rapid fire kind of thing. One is an anonymous person. Difference between CGM and AGP, that is flash glucose monitoring. When the flash glucose monitoring system, you just see what is it at that particular time. Whereas a true continuous glucose monitoring will keep on giving you the graph. It's only a it's a technical difference, and both will give you the same. For example, if you see the freestyle Libre itself, although it is a CGM, it is still a flash glucose monitor. Anytime you want, you go and get it. But over a period of time, once you've taken the thing, then you will get the graphs also filled in. So it's only a technical difference. Second is Dr. Praveen Kulkarni wants to know if HbA1c is below 6.5, it's obvious TAR is good. Is there any need to check TAR? Well, it depends. You can still check it to make sure that there are no hypos. Well, I told you the HbA1c of 6.5 just tells you it's under good control. It doesn't tell you whether TBR is there, time below range. And as Professor Joshi said, at night, for example, in an elderly person, you want to make sure by saying 6.5, you don't know anything else. But when you look at the time in range, then if you find suddenly in the night there's around 20% of the time it's under below the range, you're going to reduce it and de-intensify the treatment. You cannot do all that unless you have TAR. Just with on HbA1c, you cannot. So as you start treating more, you will learn so many things when you do TAR. And then there's the last one. What is the clinical benefits of patient maintaining TAR? The clinical benefit is obvious. I told you that. For every 10% increase in the TIR, you're going to reduce the incidence of retinopathy and nephropathy by almost 50-60%. It is huge. And therefore, if you don't test it, you don't know. You get some blood sugars here and there, you get one HbA1c here and there, you really don't know. But suppose your time in range is now 50 and you're going to increase that to 70, you're going to virtually eliminate the risk of retinopathy and nephropathy. Isn't that worth it? And the beauty is, if you don't want to keep on doing the TAR, it's not necessary. You do it now, you see that you increase the range, leave it for 3 months, 4 months, then put another one. If there's any change at any particular time, you check it. So even for some people, even a couple of times a year, 2 or 3 times a year, if you put it, should be more than enough. That way the cost will come down significantly. And all this poking, you can try to avoid.
Yes, thank you, sir. Maybe in the interest of time, I can ask one more question to Dr. Joshi. Sir, Dr. Praveen as well as Dr. Muralidharan wants to know what is your preference for glargine U300 and digludec? Both these molecules are concerned. And what is your clinical experience with?
See, as I told you that I showed you the differences of U300 insulin over and above this thing. So if it's a simple type 2 diabetes, really you can use either or. But if there is a patient with renal disease, elderly population, type 1 population, clearly I will have to choose it. So if you look at data, pure data, just look at science, from all perspectives, from pharmacokinetics to RCTs to real world. In type 1 and type 2 space, clearly I think there is an advantage with 2Geo in terms of sheer data. Yeah, and if you look at the bright 2D study, head-to-head study compared to a controlled study, definitely you have much more advantages in terms of generation of evidence based and science. Okay, both are great insulins, but I think you have some advantages in terms of numerical as well as some statistical and as well as some confidence interval superiority over the other. As I said, these are very close calls in clinical practice and personal preferences. But I would definitely use Tujo. If I have to just close my eyes and give something, I will give that.
Thank you, sir. We have questions already pouring in. So maybe in the interest of time, we can end the Q&A session now. So I would like to pass on to Nishal. Nishal, over to you.
Thank you, Arjun. So, with the interest of time, now we are concluding the webinar. So, I would like to thank my hearty thanks to our faculties, Dr. Mohan sir and Dr. Joshi sir, for the wonderful explanation on the topic and for the wonderful answers to the audience queries. So, I would like to thank our audience for their active participation. At the same time, I would like to thank our tech team for the seamless conduction of the meeting. We are looking forward to another future similar kind of interactions. Till then, goodbye, stay safe.
Hi, sir.
Thank you. I'd
Thank you.
like to thank Nishal and Arjun and my good friend Dr. Shashank Joshi for a very lively